Well, good evening all. It's just 6 o'clock and welcome to the Wednesday evening webinar. As those of you attending will know, it's a wonderful opportunity for updates regarding surgical practice, but also in the disciplines allied to surgery and particularly in those areas that impact on our day-to-day surgical practice. And those who attended last Wednesday week's webinar on diabetes will have had a really very good update. And I'm sure today's or this evening's update will be just as good and is extremely relevant to our day-to-day practice. I'm very grateful to Professor Martin Cormican, who has become a national figure really through his involvement with COVID and the recommendations for COVID. And Martin, we're very grateful to you for all of the work that you've done on behalf of the profession, but most particularly on behalf of the patients and general public in Ireland over the last 2 years. It really must have been a war of attrition on your own time, and to have been so much in the public eye must have been a great strain. So we're proud of what you did, and thank you for all of that. Martin is joined by Sinead O'Donnell, who's a senior lecturer consultant microbiologist in Beaumont Hospital, and she's going to follow on directly from Martin. And then if you have questions, please send them in on the chat function, and we can put them then to Martin and Sinead after their presentations. Then we're going to change slightly to a talk on the new guidelines on the management of the deteriorating patient. And I cannot emphasize how important early recognition of the patient who is not following the expected trajectory is. Time and time again, when somebody gets into real difficulty, you can look back and there have been signs of deterioration that simply weren't recognized or picked up or acted upon. And so I'm very grateful to Aveline Casey, who is going to talk to us about the new guidelines on the management of the deterioration patient. And I can't emphasize how important this is. So rather than go on any further, can I hand over to Martin and Sinead, and I look forward to your presentation.
Thank you very much, and thank you for your kind words about my work on COVID. I have to acknowledge that I have had some tremendous support from colleagues over the last couple of years, and I wouldn't have survived without it. So thank you for your kind words. So I'm going to talk about something entirely different than COVID for a change this evening, which is surgical antibiotic prophylaxis. So this is very much part of what our HSE antimicrobial resistance infection control group is about. And we have worked to try to continue in this area, and recognizing tremendous support work from Mari Philbin, the chief pharmacist on our team, who has helped to keep all of this going through the last couple of years. So I'll go to the next slide, please. Okay, so briefly what I'm going to just talk about is outline a case, very briefly, talk a little bit about the background and rationale for this work, the joint position statement on surgical antibiotic prophylaxis that we have agreed, and to show you some audit tools and supporting materials that may be helpful if you feel that you could use these in your practice. Next slide, please. So this is a very brief outline of a case of a 60-year-old farmer diagnosed with colon cancer requiring resection. There was no notable past medical or surgical history other than self-reported allergy to penicillin. His prophylaxis was modified because of the allergy to penicillin, and so there's a question here as to what would you use in this situation, and we will come back to that. But in another setting, I might ask for people to make suggestions. But so just to consider for yourself, faced with this situation, what would your approach to prophylaxis be in this setting? I'll go to the next slide, please. So 4 days post-op, lower part of his wound red, painful, and discharge, diagnosis of surgical site infection, a sample taken from the discharge, Microbiologists, as you will know, always want a sample before any treatment is started, because it makes things easier later on if it's get complicated. And then he started on empiric antibiotic treatment in accordance with the hospital antimicrobial prescribing guidelines. And the agent started was coamoxiclav. And this happens quite a bit because penicillin, self-reported penicillin allergy is very unreliable. And very often, I think we have all, myself included, tended to take it at face value. And sometimes a brief discussion with the patient makes it clear that it's not penicillin allergy at all. I distinctly recall seeing a patient once in a surgical ward who had been treated with less than ideal drugs to avoid beta-lactams for a period of time. And the basis for his self-reported penicillin allergy was that he had had an intramuscular injection 40 years previously. His muscle had become hard and sore, and he'd been told he was penicillin allergic, which he clearly was not. So a lot of self-reported penicillin allergy is not real. And there are studies that show that as many as 90% of people who believe they are allergic to penicillin are not. Sometimes it's very clear from the history. Sometimes you need a bit more evaluation, but it is something I think that we all need to look at more critically. So this man had a wound dehiscence on day 7. The organism that we grew was in E. coli and a Bacteroides fragilis. And just to comment that both of those are generally adequately covered by coamoxiclav. I know that many people feel that they need to use metronidazole whenever they see a Bacteroides fragilis, but we don't. They will often respond very well to a combination coamoxiclav, which is amoxicillin and clavulanic acid, has generally good activity against many anaerobes. So if this man responding to treatment, there wouldn't be a need to add anything because of the Bacteroides fragilis. And of course, the treatment is always guided by, but not always directed by, what we grow. And then the next slide, please. So responded to treatment, but as many people with surgical site infection do, and make a very good recovery, but often results in delayed discharge, delayed adjuvant chemotherapy, increased risk of an incisional hernia. So always something that is best avoided for all sorts of reasons. So if we go on to the next slide, please. So a review of the contributing factors in a situation like that. One of the things that has come up in a number of situations over the years that I've been involved with colleagues is looking at the surgical antibiotic prophylaxis. We sometimes find that there are issues about when it was started. I've seen instances of it being started too early and being started too late. When was it stopped? What agent and what dose? And how did the impact of the penicillin allergy receive on this man? So he had received erythromycin 500 milligrams IV 6 hours for 48 hours as his antibiotic prophylaxis. If we just go on to the next slide, then thank you. So again, this is a little interactive piece. At least you can interact with oh, it's gone away. There, it's back. So I'm just going to invite you to have a look at this for a moment, and you don't have to declare it, but just decide for yourself which, if any, of these combinations would you have chosen for prophylaxis for that man with the reported history of penicillin allergy. Of course, as I've touched upon, the first thing to do was to find out, was he penicillin allergy? In fact, he wasn't, but if you, in the context of the decision at the time, with the belief that he was penicillin allergic, which of these regimens would you consider using? Which would you rule out as being not appropriate? I'm just going to pause for a minute to give you a chance to look at that and choose. Okay, I'll go on to the next slide now, please. So, no prizes for guessing that the stuff that's in red with the line through it is stuff that we wouldn't recommend. So ciprofloxacin doesn't cover anaerobes, which are obviously important in this setting. So that's not an appropriate agent for this setting, not on its own. Erythromycin, I've seen this used quite a bit over the years. It's really a very poor choice for colonic surgery because it has very poor activity against the kind of organisms that we commonly find in the gut. Cefuroxime would look after things like E. coli and those kind of bugs, but isn't really very good for anaerobes. So again, as a single agent, we wouldn't recommend it. Cefuroxime and metronidazole is a choice. Again, when we ask somebody about penicillin allergy, it's really useful to find out what they mean, because very often the person will say, well, first of all, it may be apparent that they didn't have an allergy, that they had an upset tummy or something like that. They sometimes will tell you that they had a skin rash, but just a skin rash that came up a couple of 3 days after they started on the penicillin. If it's a skin rash 2 to 3 days after penicillin, then you know I'm very comfortable using a cephalosporin like cefuroxime. So this is often a good choice. Cefuroxime and metronidazole would be a good choice. You would not use it if the person gave a clear history of anaphylaxis to penicillin, then we would avoid this. But that's fairly uncommon. Happens. Ciprofloxacin and metronidazole I put in orange because that would cover most of the things we're concerned about for this prophylaxis, but it doesn't cover all. It doesn't cover everything. It's not a great cover for some of the bugs that might be in the skin and that might cause infection. But it would be, and ciprofloxacin has significant adverse effects, but that probably would work most of the time. So that's at that in orange. On 6, we have a red line through it because it doesn't cover gram-negatives at all. And then the last one is an option. Teicoplanin and metronidazole and gentamicin, you've got a gram-positive agent, you've got an anaerobe agent, you've got a gram-negative agent. So key part of the choice of prophylaxis here is choosing an agent to cover gut organisms like E. coli and Bacteroides. And most hospitals are going to have guidance that will make a suggestion for what to do if the person is penicillin allergic, and that guidance will be designed to cover the bugs that you would expect to find in the kind of surgery that you're planning to do. Go on to the next slide, please. So that's just by way of introducing the topic of getting surgical antibiotic prophylaxis right is critically important. And getting it wrong can undermine all of the skill, all the years of training that's developed that surgical technique can be undermined by getting surgical prophylaxis wrong. And you get the most benefit and the least harm with the right agent at the right dose at the right time and the right duration. And again, most hospitals where you will be working will have very clear guidance. And I know that it's sometimes the prophylaxis is seen as a detail, but it really the evidence that this is important for this kind of surgery, as you all know, is really impressive. That it's key to reducing the risk in the kind of surgery we're talking about here. There are other surgeries where prophylaxis is not required or much less important, but you know, as I say, you will have institutional guidance, I would expect, in most hospitals. So if we go to the next slide then. So the joint statement that we have worked on with the Royal College of Surgeons in Ireland, amongst many other partners, and it looked like to acknowledge the support of the Royal College of Surgeons in developing this consensus statement, along with the College of Anaesthetists and others, focuses on one issue: duration, not on the choice of agent. As I say, there will be institutional guidance on that, but on the duration. So if we go to the next slide, please. And the reason we focus on duration is because it's an area that there's a significant variation on, and we know from studies comparing Ireland with other countries like Scotland that we use surgical prophylaxis longer than they do in Scotland, and we don't have any reason to believe that results in better care. So we have good evidence internationally, as well as the published evidence, that we don't need to use a surgical prophylaxis for as long as we sometimes use it. So we've identified it on our team as an area to work with colleagues where we can make a real improvement. So for the vast majority of procedures, there's very good evidence from surgeons, not from microbiologists, that is an adequate dose of the right agent at the right time, a single dose is appropriate for most situations. Extended duration of surgical antibiotic prophylaxis is not associated with further reductions in the risk of surgical site infection. And there is evidence of harm from extended durations of surgical prophylaxis, including acute kidney injury and Clostridioides difficile infection. I'll go to the next slide, please. So what does the position statement say? Well, I'll go directly on to the next slide, and it outlines that. So the position statement is a position statement on the duration of antibiotic prophylaxis and surgery, agreed in October of last year. And one of our programs of work for this year, we hope that you will continue to support us on as you are this evening, is promoting this message to surgeons and to others. So developed jointly by the National Clinical Programme for Surgery and the HSE Antimicrobial Resistance and Infection Control Team. And there was review and feedback from an extensive group of professional groups. And so this guidance is very well supported by a consensus of all the relevant expert opinion in Ireland, and very well supported by the evidence that was looked at in drafting it. So if we go to the next slide, please. So what we have set out in the document is maximum durations of surgical antibiotic prophylaxis related to the type of surgery. As I say, most procedures do not require post-operative antibiotics. There are some types of surgery that we've identified that it may be appropriate to go for 24 hours, and some that there may be a case for going for 48 hours. Now, I would say that the evidence for going to 48 hours is not strong, but the approach that we took in developing this consensus guidance is that we would go to the maximum limit that there was any reasonable basis for going to. So where there was a reasonable basis for saying you could make a judgment that 48 hours was appropriate, we said, well, that is the maximum. Although in fact, the weight of evidence in many of these might be 24 hours. But insofar as there was a reasonable, there was reasonable uncertainty, and insofar as there was a reasonable body of professional opinion that 48 hours might be required, we took that approach. So this is a very much consensus building approach to the guidance. Some hospitals and some surgeons will use less than the maximum, and that is often entirely appropriate and often very well supported by the evidence to use less than the maximum. But the key point that we make in this, and that everybody who was consulted has agreed to, is there is no evidence at all and no basis for going beyond these periods for these kinds of surgery. So if we go to the next slide, please. So as I say, I've outlined this, that we have, where there was any reasonable basis, we said we would go for 48 hours. The guidance is applicable to both parenteral and oral routes. And importantly, the statement just makes the point that extending prophylaxis because drains are in situ is not supported by the evidence, and that it's not a reason to extend antibiotic prophylaxis. We'll go to the next slide, please. Another issue I think we called out in this short statement is the issue of differentiating clearly in how we think about it and how we approach it between prophylaxis and treatment. I have had conversations with colleagues from time to time over the years where people say that they are continuing the prophylaxis because they found evidence of infection at surgery. And of course, that's no longer prophylaxis, is one of the points that we make in these notes. You're then into a treatment modality, and then you should be guided by the empiric treatment guidance for infection, or for the or based on cultures should be taken to guide that as well. So if there is evidence of infection discovered at surgery that was not anticipated, that there wasn't appreciation that there was infection there at the time of starting surgery, then it's time to stop prophylaxis. It's time to start treatment. And in starting treatment based on guidance that specifies what agent is likely to be most effective and for how long you're going to treat it, and the duration of treatment, the duration for treatment is going to be quite different from the duration of treatment for prophylaxis. If we go to the next slide, please. So we have a number of suggestions and resources then that will help people to look at their own practice. We do know from evidence we've seen in point prevalence studies that continuation beyond 24 hours is common enough still in Ireland, and much more common than would appear to be required. The number of instances where there is a reasonable case for going to 48 hours is quite small, but there are some where, as I say, there's a reasonable case. The evidence doesn't say you need to go to 48 hours, but where it's arguable, we said that's where we set the maximum. So we might look at some of these resources, and I'd invite Mari Philbin did a lot of work in developing these. Sinead has contributed to these as well, and as of others. And so we'll go to the next slide, please. So there's an audit tool. One of the big advantages of this is I and you and all of us on this call have an audit requirement probably for our continuing professional development. This is a relatively painless way of fulfilling your audit requirement, and it addresses a really important issue in patient care. The audit data is to support quality improvement. So there is no reporting requirement. You can download the tools and you can use them to support your own practice. We suggest that a sample process would be to audit 10 consecutive patient discharges within a single specialty. In addition to the audit tool on the website, there's a video that talks you through exactly how to use it. And if you're in a situation where access to a PC is limited, you can download it to a smartphone. I'll go to the next slide, please. So again, this is just to show you how it's filled out. You've got the audit date. You've got audit date. It leads you through the questions that you need to ask about each patient. So you've got patient 1, question 1, type is the specialty, specify the procedure, surgical antibiotic prophylaxis. So there's a question for each one. There's a column for each patient. You can fill into the column the information for that patient, and then the tool allows you to generate the report that you can use to look at and that you can use as evidence of your audit. So if we go to the next slide, please. This follows through with questions. Question 5, what is the recommended maximum duration? What duration was the antibiotic given for? And a lot of these we have drop-down lists because that makes the analysis easier. So you can click on the drop-down list and click the one that's appropriate. Were antibiotics given for less than or equal to the recommended duration? And is question 7. If we go to the next slide, please. Question 8, if antibiotics were administered for greater than the recommended maximum duration, was there a specific documented reason? And if the answer was yes to question 8, then what was the reason? So if we'll go to the next slide, please. Question 10 and 11 and 12 are optional questions that enrich the output of the data, but if the information isn't available or if you choose not to collect them, you can still use the audit tool. So was the duration specified in the operative notes? Is prolonged postoperative antibiotics were prescribed? Was there a documented stop date? So as I say, these are questions that will add value to the audit, but they don't need to be completed to use the tool. If we go to the next slide, please. So then this is what the overview looks like, and you can see patients 1, 2, 3, 4, and 5 set out across the screen. If we go to the next slide. And then at a click of a button, you can generate these kind of reports that will tell you that the prophylactic antibiotics that in the practice that you've audited were prophylactic antibiotics indicated, were prophylactic antibiotics prescribed, were antibiotics given for less than or equal to the recommended duration. And we use red-green coloration. We've used this very successfully with work that we've done in general practice, encouraging a shift from being red towards being green. So this is it's a useful, we think this would be a really useful and easy tool to use. And again, if any of you do use it, we'd be very happy to hear from you about what's useful about it, how you think it could be improved. But we've tried to keep it very, stripped down, as it were, so that it's easy to use and will be useful. If we go to the next slide, please. So then you can look, if you do the audit as the audit cycle that we're all familiar with is that you do the audit, and you see, are you improving? And the tool also allows you to generate a bar chart like this that will show improvement in practice over time, which again is useful. And these kind of audits, I think, have lots of value in improving practice, but also in demonstrating that the work is ongoing to improve practice, which is often required in many kind of quality management or accreditation type models of healthcare. If we go to the next slide, please. So the supporting resources, there's an e-learning module on HSE land, which is approved for 2 CPD credits. And the intended audience is anyone who prescribes, dispenses, or administers surgical antibiotic prophylaxis. You don't have to work for the HSE to use HSE land. Anybody can register, and we hope that is useful to you. And again, as with any of the educational support materials we do, we're always happy to hear back about suggestions for improvement. So if you do use them, if you see something we could improve on, then we did have help from surgeons in doing this, but most of us who were involved in doing it aren't surgeons, so we'd be very happy to learn from you how to make it more relevant for surgeons if you have suggestions. We'll go to the next slide, please. With us posters and pens and key messaging, and we will be working and promoting this in hospitals over the next few months. And if we go to the next slide, please. And this is more leaflets for patients, which tell patients what to expect about antibiotics. All of these leaflets, we try very hard to have all of our HSE AMRIC leaflets approved by the National Adult Literacy Association, approved for plain English language, to make them user friendly for patients. And the intention with these leaflets is to support the surgeon in having a conversation with the patient about antibiotic prophylaxis, so that they understand the benefits of it and the limitations of it, and why it is that it will be stopped when it's stopped. If we go to the next slide, please. So then we have I'm just going to mention here that we have an action plan for the HSE to improve antibiotic use and over the next few years. This is part of a global movement. The World Health Organization, the European Union, the European Commission are all involved in an effort to try to improve our use of antibiotics, to protect it. And the goal here is to get the benefit for antibiotics for patients today. So there's no intention to keep antibiotics from patients who need them, but to use them wisely, so that we get the benefit today without harming the benefit that we will need in future generations. If we go to the next slide, then I think I'm almost done. So my privilege now. So again, before I finish, I just want to thank Mari Philbin, who's on with me, who really did the huge part of the work in this. And it's a great pleasure for me to introduce Dr. Sinead O'Donnell, who's a senior lecturer and a consultant microbiologist in RCSI Beaumont. And I always like to take the opportunity in public occasions to embarrass Sinead by saying that she was one of the finest specialist registrars I ever had the privilege of working with. So I look forward to hearing your presentation, Sinead.
Sinead, you're mute. Maybe you can unmute.
Thank you, Martin. As always, embarrassed by you, but thank you. So this is going to be very brief. As Martin has said, I am a senior lecturer and consultant microbiologist in RCSI in Beaumont. And my slides are not moving. Okay, so as Martin has mentioned, I was part of the group that was responsible for the position statement, and just after we had finalised that, I was appointed as a senior lecturer and microbiology consultant in Beaumont. And Beaumont has very strong links with the clinical microbiology department and with surgical colleagues, and they work very closely together to provide our surgical antimicrobial prophylaxis guidelines, which are part of our app. So we work very closely together using evidence, local epidemiology and local experience, so that we can use our guidelines to guide our surgeons in using antimicrobials appropriately. So in October of last year, I actually trialed the audit tool that Martin has mentioned, and as part of making sure that there was no bugs in it, I can tell you that there definitely isn't. It works very well. It's very easy to use. And with one of our SHOs in the department, Sinead Kilgariff, we carried out a very quick audit, and we looked at 60 of the surgical patients across all surgical specialities. And as you might know, Beaumont has a great variety from general surgery, vascular, orthopedic, and even neurosurgery. So 60 patients were reviewed, 94 of whom had received surgical antimicrobial prophylaxis. However, only 87 of them were indicated by the local guidelines. So definitely some improvement there. But the other issue was that 40% of the patients who were given prophylaxis was actually for an extended duration beyond that which was specified in our local guidelines. So definitely some improvement needed. So I jumped at the chance of putting forward a proposal for a research project, collaborating with our surgeon colleagues to get a STAR MD. So I'm delighted to say that Dr. Katie Giblin, who is a surgical tutor in RCSI, has been successful in her candidacy for her STAR MD. And in July, she will be starting a project entitled Surgical Antimicrobial Prophylaxis for Surgeons by Surgeons. So myself and Niall Stevens from the Department of Microbiology and Prof Hill from the Department of Surgery will be supervising this project over both Beaumont and Bonds Secure Hospital here in Dublin. And we're going to be looking at developing a surgically led multidisciplinary collaborative approach to improve our prophylaxis over the hospitals, because we believe that there are areas where we can modify the behaviour of prescribers, and that by using a surgically led quality improvement project, we can actually improve our use of antimicrobials. So briefly, over the 2 years of the project, we're going to be defining the problem, looking at the literature, seeing what barriers are known to exist, and then also looking at the barriers to compliance that we find in our local area. And then we'll be also looking at the roles of the various people involved in prescribing, from the patient right through to the prescribers, and see what we can do to influence those behaviours using quality improvement approaches, and identifying interventions where we can improve surgical antimicrobial prophylaxis, and hopefully be able to roll that out beyond Beaumont, beyond our local area, so that we can make this a more national project. But it hopefully will be led by and informed by our surgical colleagues. So that's my brief explanation of what I'm doing to try and help it locally. So if there's anything that you need in terms of support or quality improvement initiatives, or if you want to give us any feedback on any initiatives that you have, as Martin said, Mary would be very happy to hear from you. Thank you for your time.
Well, thank you, Sinead, and thank you very much, Martin. A couple of things have come in. Tim O'Hanrahan says the audit tool looks very helpful. As someone who has spent far too much time discontinuing inappropriate antibiotic prescribing, I welcome its introduction, and I'm sure, Sinead, if you want to reach out to Tim O'Hanrahan and colleagues in the West, they might very well join in with you. Ken Mealy says these principles regarding length or duration of prescription have been known for a long time. So why is it that in Ireland it's so difficult to get guidelines embedded in surgical practice? Martin, are we just plain stupid, or do we not read the literature? Or why are people extending for 24 hours or 48 hours when a single dose is what is the industry standard?
I mean, I think this is similar to change management issues in many other areas. We are, in spite of the fact that we have, all of us are committed in principle, myself included. So it's, we're all committed in principle to evidence-based medicine, but we are also very much creatures of habit. And it's quite hard to change what you've been used to doing. And a lot of that is about fear. And I think even though you've seen the evidence, I suppose one of the things I'm always struck by is that a surgeon invests a huge amount of themselves as well as their skill in doing a surgical procedure, and they're hugely invested in the success of it. And I think that sometimes drives all of us to make decisions that are emotionally driven rather than evidence driven. So I think it's habit. I think that you're so invested in the procedure. And I think one of the things is that people underestimate the harm. And I suppose one of the key messages we have about antibiotic, trying to get people, not just surgeons, but everybody who prescribes antibiotics, one of the key things that we try to get people to focus on is, we've all been, I think, I certainly grew up on the thing of let's give them antibiotics just in case. And the thinking that underlines that is that they'll do no harm. But of course they do harm. They do very significant harm. Some of the antibiotics I mentioned, like ciprofloxacin, are quite toxic drugs. So I think part of that is getting that shift in our minds that, you know, thinking that, oh, sure, I'll give it another 24 hours, it won't do any harm, is understandable. It's very human. It's very easy to understand when you've invested so much of yourself in the procedure, but actually it is doing harm, and we know it's not doing any good because the evidence is very well conducted to show that it doesn't do any good.
Can I just ask you, if you've got a prolonged case, something that's going on 4 or 5 hours, is there a case for giving a second dose of some antibiotics during that in order to maintain tissue levels?
Yes, and that's covered in most of the guidance, and well recognized that there is a value in continuing if it's in giving a second dose intraoperatively if there is a procedure is long and complicated. Certainly that's recognized, and again, as I say, very important, I suppose, I think I'm sure for Sinead, for Mary, for all of our teams to say, we're not trying to stop people using antibiotics where they do any good. And antibiotic stewardship is about getting people to use antibiotics where they're likely to do some good. Is just as much a part of stewardship as the piece about trying to get them to stop antibiotics where they don't do any good. We're equally invested in both. I think it's fair to say, Sinead and Mary, that, you know.
And a final question, do you think electronic prescribing is going to be the way to really enforce this, where there has to be an override rather than just an instinctive thing?
Yes, I think that will help a lot. Yeah, absolutely. And also it's instinctive, but also because it drops down for you, it's easier to say yes. I mean, one of the things I find when I do the ICU ward round, they still let me do a bit of clinical work, is that deciding what your stop, and I think this is true for treatment and everything else, is stop dates are really important. If you start the treatment and you tell yourself that you're going to stop in 7 days, it becomes much easier to stop emotionally, and we are emotional beings. It becomes much easier to stop when you get to the 7 days. Whereas if it's open-ended, then it's harder to stop when you get there. So for prophylaxis and for treatment, a great help to yourself in stopping, I think, is to set yourself a stop date when you prescribe. And that, I think, is with the drop-down lists as well, because they give you the prop of a stop list. It's easier to make the decision. And I think we've all been there with the patient who's been very sick. They're now improving. It's time to stop the antibiotics, and you're nervous because you don't want them to go back. And there's an emotional impetus to keep going. Stop dates really help you there, I think.
Well, Martin and Sinead, thank you both very much. And if we get it right, according to Martin and Sinead's prescriptions, then Aveline, you'll have much less work to do because they won't get sick post-op. But Aveline is the lead for the Deterioration Patient Improvement Program. And as I said at the outset, this is a hugely important piece of work. And so often we come across somebody who is an extremist. And if you look back, the signs were there well before they were recognized. So Aveline, thank you for sharing your thoughts with us this evening, and I look forward to your presentation.
Okay, my pleasure, and thank you very much for the invite. I'll try and be expedient as I can, because I know everybody's under pressure and it's getting late in the evening. So I suppose just on this first slide is kind of a quick update as to where we are, what happened in 2018. The DPIP is the Deteriorating Patient Improvement Programme. Was established. Shortly after that, we did a quality assurance and verification audit, which informed us a lot about what was happening in the system. The Department of Health sponsored a HIB CISR literature review for us to update the literature, and that took nearly 2 years. The literature had grown, and in a 2-year period had doubled the previous literature review, which had been finished in 2015. We established a consultant advisory group, and Professor Debbie McNamara sat on that from us to advise us with regard to surgery and, help us with some of our key clinical questions. And we use NICLAS clinical data to look at some of the data around, and I'll show you some slides we have around that. In 2020, we launched the guideline. We went through a rigorous NCEC process, National Clinical Effectiveness Committee in the Department of Health process for that, and it was relaunched by the Department of Health. So I suppose some of the key pieces that I'll talk about maybe as we move forward in our project was our NOCA feasibility study around deteriorating patient and what could we look at and what kind of audits could we do. The SAFE program that we run, situation awareness for everyone, we run that with the RCPI. Digital iNews, this is really exciting, so I'll take two little pieces about what we're doing on that. The in-hospital cardiac arrest audit, what we're trying to, I suppose, achieve with doing that and where we've gotten with it. And advanced nurse practitioners in critical care outreach and our work with the National Critical Care Programme around that. Older persons is another piece that emerged from COVID and what we plan to do with that. So next slide, please. So as I said, in 2013, we had the news guideline, which was launched by the then Minister for Health. And then I suppose it should have been reviewed within 3 years, but these are huge guidelines. A lot of work has to go into them. And if you want to co-design something so it will work effectively, it takes a lot of focus groups, it takes a lot of steering groups and all of that to achieve where you need to be. So in 2020, we launched the revised guideline. I suppose one of the key things that I want to bring out about this is that in all our focus groups and in all the meetings that we had, one of the key things was people wanted to move away from a sense of care or by numbers, which this guideline is definitely not about. So clinical judgment takes primacy here. Clinical judgment is everything, and it's to encourage people to use their clinical judgment, rely on their clinical judgment and bring that to the fore. So just to say that at the start. Next slide, please. So just to take you through a few of the things that changed on the in the background and on the chart. So we changed the title from news to iNews, and this became really evident and important to us, particularly within the pandemic, because a lot of GPs actually were contacting us and wanted to use the parameters and the scoring key, but they were using news because of the, I suppose, when you look up news online, you got the UK news, and they use different parameters. We use the evidence-based parameters. They use some, I suppose, professional preferences in theirs. We also changed from the National Early Warning Score to a National Early Warning System. So we're now moved beyond just a tracker trigger tool or an observation chart at the end of the bed. So it's a whole system and a whole wraparound system, and I'll talk more about that. As I said, the emphasis on clinical judgment, and that became, a real key piece from staff from all disciplines that fed back to us. Recognition of the healthcare worker, patient and family concern is a key indicator for deterioration. There's a section on the top of the chart for that now. We know from review of incidents that family members are often the people who raise concerns and they're not listened to and a patient deteriorates. So we know that from instance in claims and state claims agency. And I suppose there's been a lot of work done in that area. And we actually had patients sitting on our guideline groups, our education development groups, and that was hugely informative. There's an increased emphasis on changes in respiratory rate as an early indicator of deterioration. What we've found in the audits and in the reviews, you can walk onto a ward of 30 patients and all those patients are likely to have a respiratory rate recorded of 18. Now that's not physiologically possible, but that's what's happening. So people had lost, I suppose, and nurses, if you look now, if you went into your hospital tomorrow and looked, you'll find very few nurses with a fob watch on, yet they have no wristwatch either. If you stop and ask them how are they counting respirations, some of them will just look at you because they're not, and some will be quick enough to say, oh, I use my phone. Which again, really in terms of infection control and everything else is not really where it's at. So we had to try and recreate an emphasis on that because it is an earlier indication of deterioration. We also looked then to, other, so Pews and Cincinnati Children's, and we wanted to create that whole situation awareness. So, identifying deterioration before it begins, or prompting staff. So things like a lot of feedback came back around increasing O2 requirements to maintain your SpO2 levels. There's a lot of feedback that staff didn't recognise that having to increase the oxygen was a sign of deterioration just to maintain levels. So things like that we're trying to prompt staff into thinking about. You'll all be very familiar with patients located outside their specialist ward. I'm sure you experience that all the time in surgery. You have medical patients in the middle of medical wards and surgical, and often with complex treatments going on that nobody is familiar with within that ward environment. So we're trying to make people think about that and what they need to do and how they need to make it safe. We also, one of the key things was nurse intuition, that gut feeling. So we wanted to capture, you have patients with a 0 to 3 score, which wouldn't necessarily escalate, but somebody's just know that there's something wrong with this patient. So we want to reassure staff, that they can escalate in those circumstances, or a junior doctor or anybody. It's not just about nursing. So we were trying to, even though we say nurse intuition here, it's well documented, well evidence-based, so we were really trying to focus on that. We also, you'll see there on the in the green highlighted area on the right-hand side there, the sepsis alert, which is very important to us, and we work very closely with the sepsis programme. Next slide, please. So then another addition to our chart is new confusion as a key earlier sign of deterioration. So your AVPU that you're all familiar with.
I think, yeah, new confusion. Yes, we've got it now. Thanks.
Oh, bye. Sorry. So new confusion. Now your AVPU now becomes your ACVPU. We did a process map of patients' observations, and we found that a patient who came into hospital could potentially not have any observations done other than one set in a 12-hour period. And we did that process mapping with the clinical advisory group, and we arrived at patients should have 6-hourly observations for the first 24 hours. Adjustments to INU's parameters and score are not permitted. They were never permitted in the old guideline, and it's a practice that crept in. And effectively, if you adjust the parameters on the guideline, you're effectively taking the person off the early warning system. So to address that issue, what we have developed is a modified escalation and response protocol, and we developed that with registrars and our consultant advisory group. We also, on listening to our junior doctors and the registrars, listen, we heard about, they're called to patients, and when they arrive at the patient, say the patient is lying flat in the bed, and simply elevating the patient and replacing their oxygen mask would have avoided a call. So what we've done to address that is we've created an option for a short period to defer escalation for the RGN. So an experienced nurse, if she knows that, well, if she administers analgesia, she won't need to call anyone, she can give the analgesia, defer the escalation, review the patient again, and then move on. So I think they're very useful. They've certainly, the feedback from the system has been very useful. Next slide, please. This slide is just to show you what on the chart, what the deferred escalation for the registered nurse looks like and what she has to fill in. Next slide, please. Again, this is the modified escalation and response protocol. This is for the consultant and the registrar, and this is reviewed every 24 hours. And this is for patients, we often hear really about COPD patients who are on oxygen and they're continuing to alert, but they're actually stable in condition. Now, you could argue, well, you should either be improving or you should be disimproving, but stable isn't going anywhere either in treatment. But we have to allow for real life and what really happens on the ward. So this has been our way of addressing it. So far, our feedback has been very positive. I had forgotten to mention and put in my slides there, and Professor Cormack was talking about it. There's also an audit tool to support all of this within the hospital environment, and it's built very much similar to Professor Cormack's audit tool there, and provides reports for staff. There's also an education programme both for doctors and for nurses on HSE land. There's posters and everything on the website. But I suppose to move then to the next part of our programme and our work. So next slide, please. So what do we know? So what do we know that's happening in the system? What do we need to look at? And what we're trying to do is find the evidence to say is, where do we need to move to and what do we need to improve? Next slide, please. So in-hospital cardiac arrest is an established outcome indicator for measuring quality improvement for deteriorating patients. So in the absence of a national in-hospital cardiac pulmonary arrest audit, we undertook work with NICUS Clinical using HYPE data to establish and find, what data could we see. Now, unfortunately, well, not unfortunately, but in-hospital cardiac arrest is a secondary diagnosis. So the data isn't terribly reliable, but it's all we have at the minute. And what this has shown is the number of cardiac arrests per 1,000 discharges. And we looked at it over a 6-year period. In Model 3 and Model 4 hospitals is where we looked at this. And I suppose what it's shown is, it shows us very clearly that there's seasonal variation within it. It does show when we had focus, so things like the audit, which brought news back into focus, we seem to get a bit of an improvement. When we had the focus groups, because people were coming from all over the country, and with the steering groups, we got a bit of improvement. And what's key there, the COVID pandemic, there's quite a dip. Now you'd say first off, well, there's a dip in admissions, and that's why you have a dip there. But actually, if you think about it, and this is it's curious, it's just being curious about it. The patients that come in were sicker patients. So you'd have to wonder things like cohorting the patients, because the patients were the respiratory patients, the COVID patients, they were all cohorted in one area. They had team-based nursing team-based care between doctors and nurses to avoid people going from different areas. There was anticipatory care, so people had anticipated these patients were going to deteriorate. Did that create a significant, we'll say, improvement in the in-hospital cardiac arrest rates? So there are things to be curious about. There are things that we want to explore more and understand more. This slide is again the data per hospital, and obviously I've taken the hospitals off of it. And what this is shown is it's ordered from the fewest to the most discharges. And what it does is, I suppose, it shows variability, but because this data is so unreliable, I suppose in one way you could say, you can't use it for comparisons, but it is there to make us curious. So you'd wonder why Hospital 23 there, who has fewer admissions, has such a significant high rate based on the data that's in NICUS Clinical, which is totally dependent on how it's input. But you would be curious about that. There's other hospitals on the right-hand side of the graph that have very low rate and have very high discharge rates. So why are they so low? What's so good about their system? Is that a data issue, or actually have they got a good system and have they got a good rate? These are all things that we're curious about, and what we're hoping with our as we move forward with our audit piece is that hospitals will start looking at their own in-hospital cardiac arrest rates and bring it to their mortality, morbidity review meetings or their deteriorating patients committee, and start looking at that and understanding their data better and how they can improve it. The next slide is the NOCA ICU, National ICU Audit. Unplanned admissions to ICU is another, I suppose, outcome indicator for deteriorating patients. So when we look at this data from the ICU audit, which majority of the acute hospitals are in, so if you look there, 21% of patients that go to ICU come from the ward, 40% from theatre. But of the 21% of patients who go from the ward, they're the sickest patients with the highest Apache, on average, they're the sickest patients with the highest Apache 2 scores, they have the longest lengths of stay, and they have the highest average mortality rate. So clearly it's saying to us here that there's something, if we can improve that 21%, we improve things in terms of our capacity and in terms of our care in our ICU. We know from the report that Ireland has a great proportion of patients in ICU admitted from general wards due to in-hospital cardiac arrest or multi-organ failure compared to the UK units, where in patients require ICU admission after CPR. This can be an indicator of clinical deterioration in the wards, and those patients have a worse prognosis in ICU. We know this from all our data that we've looked at with our ICU colleagues. I suppose, improving that, as I said, would improve, I suppose, some of our capacity. We also looking at the ICU data that, sepsis is a leading reason for admission to ICU, and the severity of illness usually affects the period before admission to ICU and possibly indicates delay. delay in admission or delay in recognising deterioration. We also, when you look at the acute kidney injury statistics and data for admissions to ICU, that's quite reflective too of maybe what's happening prior to admission to ICU. Next slide, please. So we commissioned a study with NOCA to determine how could we best look at our data around deteriorating patients. And really, in reality, the only way we can look at it is in hospital cardiac arrest. But one of the interesting things from this slide here is, you know, if you look at the length of stay and the cost of the length of stay, so the patient who has cardiopulmonary arrest before ICU admission has substantial more cost associated and a longer length of stay, and you'll see some of the other efficiencies around that as well. Next slide, please. So our next slide then is really, I suppose, it's our wraparound. This is our big I suppose our big change drivers in terms of what we want to do. So I've already said that anticipation is a key part of what we want to do. So safety huddles. So we've been running the SAFE program with the RCPI. We've had 34 hospitals teams. Each team has to have a consultant lead, so that's 34 consultants who have led teams to do this program. I mean, it's a drop in the ocean really, but the feedback that we're getting from the program, and people use QI methodology when you participate in the program, so people are measuring what's happening in their ward environment. They're getting improvements in, you know, lengths of stay, and improvements in discharges, all kinds of various measures that they want to measure themselves. Patient cohorting, I don't think as surgeons I'd have to convince you that you know, really is, we should be looking at that. It happened during COVID. Unfortunately, it doesn't happen again. The ED crisis tends to push patients up to everywhere and anywhere. And really, if we start looking even at cohort in our respiratory patients, we could probably do significantly better in terms of unplanned admissions to ICU, unanticipated cardiac arrest, and reduce lengths of stay and create different capacities. Reliable recognition then is the next part in our whole wraparound. Reliable recognition. So digital INUs, and I'll speak a little bit about that for you. The older persons piece arose from COVID, older person residential care, looking for ways to identify deterioration earlier. Education, obviously, as I said, we have the e-learning and conference and events. Our response piece, it's a really exciting piece of work that we're doing with the National Critical Care Programme. 2 years ago, we had 6 registered advanced nurse practitioners in critical care outreach. By the end of this year, there'll be 47. So this is a growing piece. So, you know, within your own hospitals, there's the 9 Model 4 hospitals all have advanced nurse practitioners now in critical care, and 5 of the Model 3 hospitals. So this is something I suppose I would say to look at, inquire about in your own hospitals, and see how can those advanced nurse practitioners support surgical patients post-surgery and in terms of deterioration. And then the governance piece, really our focus is on in-hospital cardiac arrest, because that's the way we'll drive improvement within the system. And quality assurance verification, they complete national audits on INUs and IMUs. Next slide, please. The SAFE programme, I won't dwell too long on it, just you can see there from the slides, and you'll be able to get them later, the feedback that we had from staff participating in it. And I suppose, you know, if you have if you run a safety huddle, I suppose it ensures that the patients, everyone knows what the plan is. Everyone knows their part in the plan, and everyone knows how to move forward, and action will be taken in a timely way. So I suppose that's what you're trying to achieve with it. You're trying to, I suppose, really anticipate, and it's a no-brainer in one way. And you know, somebody asked the question earlier, if we know all of this, why don't we do it? Well, you know, it's all about changing behaviours, it's all about changing culture. And if we want, you know, we have trouble retaining staff, people who do this programme or participate in huddles feel very valued, and they feel that there's safety, you know, there's psychological safety in the huddles. So these are the kind of things that we need to use that will help retain staff, not by their own, but as part of that whole staff retention piece. Next slide, please. So I talked a bit about the digital iNews. This is really exciting. So we're bringing the digital iNews system into 19 acute hospitals, only a single ward, and it's mostly respiratory wards, COVID wards that it's going into. It's part of that response to COVID. But you can see there on the left-hand side of this slide, you can see your normal observation chart. We had human factors expert look at our chart and work with us to redesign the chart. But in doing that work, we found out that there was 39 opportunities for human error with every set of observations. So if you take that to a 30-bedded ward and a minimum of 4 sets of observations for each patient in that ward every day, and on each set of those observations, 39 potential errors. It just shows you how complex it is. So that's very simply, the middle chart is the digital version, what it looks like in the digital version. And then to the very right, that's the WOW, as they call them now, the workstation on wheels. On the top of that, the screen part there, what you'll be interested in is not only does that show the observation chart, and it's populated automatically when the nurse is doing her blood pressure, her temperature and her pulse oximetry and respiratory rate, and it scores it automatically. But as a doctor doing your round, you bring the WOW with you, and there's tabs on that you can bring up your X-rays, your labs, your and in the future the pharmacy. And somebody asked a question about that there. So it works for everybody. This is not just a nursing piece, but I mean, you know, over 70,000 people would be using this in a daily basis. So we really have to create a demand for this and move it beyond just a single ward in 19 hospitals. Next slide, please. The critical care outreach team. That's just a slide to tell you what they're about, what they do. And as I said, we're now looking at having be 47 AMPs across the country. We know that their impact, we know in sites, Galway, for instance, has a team of 7 AMPs, so they have a 24/7 service, or they're achieving their 24/7 service. We know the data, there's a 75% reduction in ICU readmissions. That's phenomenal, and I'm sure that's something that you'd all be interested in terms of you're getting access to ICU. I mean, to achieve that is brilliant in itself. Intervening earlier, I suppose patients less sick are going into ICU, so that reduces length of stay. Supporting staff, educating staff. This is certainly not about a hero service rushing in with a cape and doing everything. This is more about educating, supporting. Junior doctors need support on the wards, nurses need support on the wards. So, you know, advanced practitioners in this kind of area, again, that helps an unintended, if you want to call it unintended consequence of, I suppose, you know, staff retention. All these things help. Next slide, please. The governance piece I spoke about, and I spoke what we were trying to do. We made a business case. We did our feasibility study with NOCA. We developed a collaborative business case. We submitted it, and unfortunately, we didn't get any funding in the service plan this year. But we have resuscitation officers in every single acute hospital. We did a survey, 75% of them collect data, but none of them collect the same data. So we know that there are Unstein guidelines, you know, with regard to the data you collect for in-hospital cardiac arrests. We know internationally, you know, out of 26, I think it is, European sites, 18 have an in-hospital cardiac arrest audit, national audit. So we need to be progressing towards that. So we're going to work with the resuscitation officers, and we have some clinical leads who are very interested in this, who are going to work with us. And what we'd hope to do is develop our template, roll it out in sites, and have sites bring it to their own hospitals. So it's not national, but at least we're starting with hospitals and driving that improvement at hospital base. Next slide, please. So I suppose I was always told, if you ever go into a room with influential people, have your asks. I suppose my asks of you are, in terms of anticipation, consider safety huddles, you know, inquire about them if you're not familiar with them. If you don't believe in them, maybe have a look at them, maybe see some of the evidence, and consider them for your own environs. Patient cohorting, again, you know, I worked in the SDU. I strongly believe in the potential of patient cohorting. I think it would help us address some of our our bed difficulties and our safety for patients. Reliable recognition, encourage adoption of iNews V2 within your own sites, and I suppose advocate for the digital iNews system. Have a look at it when on the ward that it goes into in your hospital, and I suppose the more people that advocate, the better chance we have of getting it. Because it's the potential for it not just to tell us the observations of the patient at the bedside, but to actually give us operational grip within our hospitals. So when you talk about rounding and maybe days gone by, so you come on duty, you could pull off a report that will tell you where all the acutely ill patients are. You can make your decisions about where to send your team first, or where as a practitioner you need to go first. You can see where it's busy, where it's not. In terms of ICU dependency, we'd be able to predict, what's going to happen, where we need ICU beds. And then the research potential for it is absolutely phenomenal. To have that kind of data, we could potentially be world leaders in deterioration, rather than being following with paper charts. So the potential in the digital iNews system is just phenomenal. The A&P response teams, see, how the A&Ps would work within your own service, how they can support your teams to deliver care, and they're linked to a Department of Health policy. So the Department of Health are looking to create 3% of the nursing workforce to be A&Ps. So there's opportunity there to get this resource. So it's not that it's not. And the digital iNews piece is linked to the medications device replacement, of which there's 65 million dedicated for the next 5 years for hospitals. So that's another piece, that there is money behind. So there's potential to achieve these. The governance piece, as I talked about, if you've your mortality, morbidity meetings, again, looking at this kind of data, the ICU unplanned admission data, the in-hospital cardiac arrest data, they're all key drivers for improvement. And I suppose that's it. They're my asks of you, and I hope you found this talk beneficial. Thank you.
Well, Evelyn, thank you so much. And it is an enormous amount of work that you and your colleagues have invested in this over the last 5 or 6 years. So congratulations. I have to say that it must have been very disappointing not to be funded this year, given the extraordinarily persuasive case that is there. I mean, it is actually so blindingly self-evident, and yet you now have the data to support that self-evidence, and it is cost-effective. 6 hours delay in getting somebody to intensive care can equate to 6 weeks longer in intensive care.
Exactly.
And the cost of that in our system is unconscionable. And so often, as a practicing clinician, we have been on the ward knowing that there's somebody needs to be there, and our colleagues in intensive care, with the best will in the world, simply can't take them because we don't have the capacity.
Yeah.
So the very fact that the ANPs in Galway have reduced the readmission rate by 75% is simply a stunning figure.
Yeah.
And there should be no hospital with an intensive care in this country that's not able to replicate that if it can be done in Galway.
Yeah, exactly. There's huge potential, and to sustain that, maintain it. There's such potential out there, and I think by people collaborating, coming together, and rather than seeing maybe resisting or what's this about, is actually saying, well, how do we make this work for us? How does that affect us? And everything is linked in healthcare. It's all a network of links. So what I do affects everything else, as a practitioner. So I think that's where we need to look at, and how do we all collaborate? How do we make it work for us? And little wins all build up, to create capacity. So
indeed, and your comments about patient cohorting couldn't be more appropriate. The worst place for a surgical patient to be is on a medical ward, and vice versa.
Yeah.
And it's not because the clinicians aren't au fait, and they aren't, but it's the nursing staff are not accustomed to looking at.
Yeah.
And unfortunately, we have lost this concept of the surgical ward and the renal ward and the respiratory ward. It's wherever there's a bed to relieve the pressure on the ED.
Yeah.
So I have to say, I'm sure all of us who have listened in this evening are immensely impressed, and thank you and wish you well. And I think we should look to have you back next year for an update to see how we are progressing, and any way that the college can support this. I know that my colleagues and I will do so. So well done. And
thank you.
Thank all of you who have listened in this evening. I thank Martin Cormican and Sinead O'Donnell for a very interesting first half. And thank you again, Evelyn, for a very interesting presentation, and well done. And good evening to everybody, and thank you for your participation.